A very good evening to everyone present here. On behalf of Artist and Farmhead, it is my pleasure to welcome you all to this insightful academic webinar focused on one of the most challenging and evolving areas in women's healthcare, endometriosis, emerging perspectives in diagnosis, decision making, and management. Today, we bring together a distinguished panel of experts who will share their perspectives on how technology, evidence-based medicine, and fertility-focused approaches are shaping the future of endometriosis care. This session will explore the role of artificial intelligence in clinical decision-making, the growing preference for medical management, and the fertility implications of this complex condition. We are privileged to have with us eminent leaders who have made remarkable
Recording
contributions to women's health, reproductive medicine,
recording
research, and education. I am confident that today's discussion will provide valuable insights for all practicing clinicians. Let me now introduce our moderator. She is none other than Dr. Hema Divakar, one of India's most respected leaders in women's healthcare. She is the CEO and chairman of Artists for Her, medical director of the Divakar Specialty Hospital, Bengaluru, former president of Foxy, member of the FIGO executive board, and a technical advisor group member to the Ministry of Health and Family Welfare. A visionary clinician, educator, and policy advocate, Dr. Hema has dedicated her career to advancing women's health across the life course. Her numerous national and international recognitions reflect her outstanding contributions to healthcare, leadership, and social impact. I would now hand over to Dr. Hema to set the tone for today's meeting.
Thank you so much, Purni. Purni is one of the greatest assets that Artist has. As you all know, Artist expands as Asian Research and Training Institute for Skill Transfer and the Knowledge Cafe series. We believe a lot can happen over coffee, and that's why we've labeled the series as the Knowledge Cafe, and the insightful deliberations this evening by three of my very beloved friends and colleagues, very distinguished in the field of OBGYN, are going to be presenting on the entire spectrum of the changing trends in management of endometriosis. It is said that change is constant. Well, we, in the last 4 decades of practice, have experienced and perceived changes almost every minute, inclusive of the changes of terminology, the most recent one being PCOS to PMOS. Well, being involved in the diabetes space, we tried to change the GDM to HIP, HIP, hyperglycemia and pregnancy, and it didn't strike a familiar signal. The HIP had nothing to do with diabetes and pregnancy. So we said, why can't we just call it DIP? Because it's diabetes and pregnancy. And we dipped into another sea of confusion. So starting from nomenclature, right from there, how the trends are changing. So this topic indeed is going to be very interesting because we need to think through, we need to reflect, we need to see what better we can do to deliver the best of care to every girl, every woman. So I hand it back to Dr. Purni to introduce our first speaker all the way from London. Thank you, Anu, for being here with us and keeping to the next generation trends. Anu is going to speak all about the exciting field of health technology, how the AI will help us in our decision making. So for a formal introduction, I hand over back to Dr. Purni.
Thank you, ma'am. As Dr. Hema said, our first expert panelist for the day is Dr. Anu Chawla. She's an internationally recognized fertility specialist and reproductive medicine expert. She serves as director of London Fertility Clinic and is the chairperson of the Endometriosis Committee of Foxy, a member of FIGO's Well Women Committee and the Royal College of Obstetricians and Gynecologists UK. Dr. Chawla has been at the forefront of advancing reproductive health care. Her work has earned her several prestigious accolades, including the International Achiever Award and Woman Icon of the Year Award. Today, she will share her insights on the transformative role of artificial intelligence in clinical decision making. Over to you, Dr. Anu Chawla.
Thank you very much, Dr. Purni, for very kind words. Thank you, Dr. Divakar, for very prestigious platform given to me today on your very polite and very sorted invitation. I always look forward to yours. And Dr. G.V. Divakar, thank you very much. My other co-panelists, Dr. Patil and Dr. Ramni Devi, thank you so much. And to all the listeners, thank you for taking time to join us today. So I'll share my screen now. So let me know if you're able to see this.
Yes.
Okay. All right.
Yes, Anu.
Should be
Yeah.
visible. All right. So the topic that Dr. Divakar has given me today is very close to my heart. As you all know, I'm currently serving my last year of the 3-year term as the chairperson of Endometriosis Committee of FOXI. So we know that this is something which is commonly considered as a final frontier, in the sense that a lot of my seniors have been calling it as an enigmatic disease. And unfortunately, I also in my generation have to call the same thing, because we currently do not even have the basic understanding of why this happens and what is the right therapy. We know that there is no drug, there is no medicine which actually directly corrects or cures the disease. We only downregulate and we think we have looked after it, but we are basically just suppressing the whole reproductive system by downregulating in some way. Recently, there are new therapies like Dynogest, but even they are working on the belief that we actually are looking at the estrogen and progesterone receptors of the disease rather than the deeper causative factor. And hence, suppressing hormones is not always going to serve the female's body correctly, and then the side effects are not very justified. And women think generally that they are not being heard, and it is becoming a political narrative. However, the real problem is the doctors don't know what to do, because we don't have the treatment. All we can offer is a medical therapy in terms of some sort of downregulation, and that is not always in the favor of women. So there is a gap here. And there's a lot of, so 70% of all the publications that ever happened in the subject of endometriosis only happened in the last 18 years. So if you go at PubMed, you will see this figure. And that means that if you do very good studies with outcome parameters that we need, for example, if you put live birth as the outcome parameter of your fertility related study in endometriosis patient, your paper is very likely to get accepted. So with this, now I start a little overview on what are we doing currently in terms of the novel and emerging therapeutic frontiers. So we know that there has been a lot of emphasis on the evidence-based medicine in the last 2 decades. And previously, our older seniors used to narrate case studies during lunch breaks, during our training. So that was clinical experience-based medicine. But looking forward, it's not only evidence-based, but it's a context-based, combining the two, because it's not always possible to have study ready for everything. Our understanding has been massively increased by the primary NZN classification, which first was based on DIE. However, the modern one has extended beyond DIE, starting from 2021 version of the modern NZN classification. And one of the authors is my very close colleague who regularly does surgeries at our center, who is Ertan Saradogan. So he's one of the authors, and the other person, Joe Kirstein, has got something which is literally revolutionizing the understanding and the management of the disease in terms of the heavy incorporation of AI in some project that we will talk about. This classification focuses on the location and the extent and the size of the disease, and hence is far better than the conventional classification systems that we have been following. So, for example, this is an AI open source system, which is accessible to everybody. So this is called Glenda. This is the gynecological laparoscopy endometriosis data set. So in the beginning, we started with 500 images, but as of late, we almost have 30,000 approved images. So this is 25 million of them were submitted, and anybody can submit. So for example, if you do your surgery tomorrow, you can actually upload your images into this system, and somebody is at the back end going to filter them and incorporate into the learning of this open source AI system. As we know that the disease can be very variable. It could be fibrotic, it could be red, white, different types of appearances, starting from powder burn basic lesions, which are simply black dots. And these generally need a lot of trained eyes to be identified. And hence, what happens is that when you use Glenda and you incorporate that into your operative system, the moment you focus the camera of the laparoscope into the pelvis, it will start identifying and flashing lesions like this. So even a new trainee will not have a huge gap from the teacher. So the trainee and the trainer's gap is being uh, condensed here by highlighting the lesions with the help of AI. And this is an open source platform. And it would be interesting if anybody who's doing surgeries regularly for endometriosis can upload their images, because this will help the open source to get better. It's like the new version of ChatGPT every few months. So this is the future of surgery, and the image recognition is something. This platform is being developed in south of France, in Marseille. And we know that in 1950s and 60s, we had rule-based algorithms to assist diagnosis and treatment. And then in 1990s, we had the image analysis and computer-aided diagnostics already. The bigger breakthroughs started coming in 2010s, in which we had predictive modeling coming up already in the subjects which are heavily using that, which are radiology, dermatology, oncology, and gastroenterology. In our subject, the use still remains limited due to ethical and regulatory and obviously technical challenges. However, the early milestones are emerging in the forms of platforms like Glenda and other platforms which are also being going to be discussed in this presentation today. So the role of AI in reproductive medicine, the refined overview is that despite public assumptions about the general AI in medicine, including REI, it currently utilizes only a narrow form of AI. It's a descriptive terminology that is being used in the text and publication. So looking ahead, generative AI powered systems will enable advanced human-like interactions with patients, facilitating continuous and high-fidelity data acquisition. This persistent and context-aware engagement will enhance the precision of the predictive modeling, allowing for more accurate forecasts of patient trajectories and potential clinical outcomes. So the enhanced outcomes through artificial intelligence in healthcare are largely based on diagnostic precision, accelerated data analysis, minimize subjective bias, enhance quality control, increase accessibility to care, ongoing knowledge integration and learning, and scalable solutions for the widespread use of the subject, and how AI is transforming particularly endometriosis patients, and even more specifically in fertility, would be that first of all, we start by detecting more accurately for the subtle signs of DIE, because we now have integrated systems with our ultrasound and MRIs. And I would suggest that even MRI is not very often needed if ultrasound is done by the trained eyes. The use of MRI is heavily because of the fact that in many cultures, still the gynecologists are not doing their own imaging, which is ultrasound. And this identifies endometriomas, adhesions missed by conventional analysis, and it improves early detection and staging. Glenda is one of them, and the other one, which I'm going to also highlight in this presentation, is called Female Project. It's very, very interesting. And predictive modeling for personalized planning. So we have the loaded data of age, AMH, endometriotic stage, surgical history, ovarian reserves, and it helps us giving the patient a very objective answer in which you have kept the balance of the degrees of stress on each aspect to be able to answer the important questions to the patient, that how early should she resort to IVF, or is the repeat surgery beneficial, and can we expect spontaneous conception? Planning optimization in the terms of pinpoints whether it's the endometriomas and the subtle fertility threatening changes happening, also supports the timely fertility preservation, because it's not always a good idea to just close your eyes and do the same thing for every patient, of course. In the terms of embryo selection, we integrate this in our embryoscope, and these days we all know embryoscopes come with the AI software if you may want to incorporate that. So these things, they track the milestones, at a certain stage, the embryo should look like this, it should be this many cells, and all those milestones, the morphokinetics, the cell division anomalies, improves the accuracy of the viability prediction. So we all know we want to avoid, as far as possible, the invasive nature of the other options, which is something like PGTA. So we have platforms like Life Whisperer, Violet, and they are very widely being used. As simple as something called as Erica, which is from Mexico, in which you simply take the normal inverted microscope pictures and put it in the cloud, and they'll give you the accuracy of 85% as compared to the PGTA itself. So just a non-invasive therapy, a non-invasive modality, giving you 85% of correlation with something as invasive as the full biopsy. And this paper is published in Lancet already. The other one is the enhancing the endometrial receptivity assessment. We have always given more weightage to embryo as compared to the lining. However, we all see that lining plays a huge role in many cases, especially when we speak about how prevalent is tuberculosis in India. Then we have AI-based decision support tools. Next best step is whether she should try IUI or IVF or repeat laparoscopy. And the platforms like Glenda, Violet, AIVF, and Female Project will give answers more objectively to a particular case once you feed all the data. So it's almost like an assistant on your laptop screen while you're seeing a patient, so that you give the best options to the patients, and ultimately the patients do decide what they want to do. So from the diagnosis to embryo transfer, AI empowers the clinicians to personalize and optimize fertility care in endometriosis with earlier decisions, better outcomes, and less guesswork. In my practice, I'm now heavily dependent on AI gadgets sitting next to me. So this is a very important paper in which basically this is saying that when you use the PGTA via AI, it drastically decreases the biochemical pregnancy rate when you choose the embryos through not just PGTA, but PGTA with AI. And it increases the outcome parameters of live birth rate when compared with the standard NGS. So this is something which is the final frontier for for example, a case of recurrent pregnancy losses in which you have done the basic evaluation, you don't find any problem. This is your last weapon. It's called STEED. It's called STEED, which is the single euploid embryo transfer. So this another paper is AI-based implantation genetic tech tool. Short, that it has a strong clinical application for the deselection of at-risk. Sorry for the complicated language, but that makes most sense. So basically, you'd leave the ones which are at risk for aneuploidy to prevent the unnecessary PGTA biopsy itself. So you don't even attempt the biopsy, which are high risk for aneuploidies. And obviously, we all know that even in the best hands, the percentage of error of PGTA is 7%. So that means in 7 out of 100 cases, you're going to tell the patient to discard the embryo, which may actually give them the last chance. So this is important. Then another, so AI is also this paper I incorporated just to show you this slide, that this is how they have integrated the neural network model, how they train it, when they have used the AI models to diagnose the rectosigmoid endometriosis in the terms that should we operate or not operate this patient before the further treatment. Now, if it is too complicated, then maybe take a break and bring your attention to this slide, because this is the most important slide of the presentation, I would say. In the beginning, like I mentioned at the outset, that we haven't yet understood endometriosis. We are just switching it off. Like one appliance is not working well, you just switch off the whole electricity on the background. This is the treatment that is being given to the endometriosis patients. So if we really understand the actual lesion, that lesion itself, that tissue is made up of immune cells, stromal cells, epithelial cells, and they may behave very differently and contribute to the disease in a different way. And that is why not all endometriosis patients are similar. And think of this lesion as a crowd of people all talking at once, because there are different sets, the whole different chemistry behind them. So what this technique does is, the single cell transcriptomics lets you listen to each person individually. It defines further whether it's an epithelial cells or stromal cells or immune cells working more here. And that is why so much of variation of the lesions also is present. So then you can find that who's shouting, who's whispering, or who's starting the trouble. So what is the degree of contribution of the set of lesions behind the actual lesion that you can see with the naked eye? So it reveals the cellular heterogeneity, first of all, in the lesion itself. Then it identifies the contributing cell populations, and then the novel insights for biomarker can be developed. So we basically have deconstruction of the human endometrial cell states, which is happening with this single cell transcriptomics, is very important towards the understanding of the disease and how to develop the right drug. And then modeling endometriosis in human normal endometrial organoids. Taken together, we all have to step back and see that whenever we change our understanding of practice of a certain pathology, we do integrate various understandings and not heavily incorporate one aspect of the new understanding. And there's an ethical aspect to that. We'll also come to that. But before that, this is something very interesting I want to share with all of you. So this is not open source like Glenda. So it's still not open source, but the intention is eventually it will be. However, right now it's a European Union funded local project of Europe. It's basically finding endometriosis using machine learning. So the acronym is FEMALE. It's a platform that converts the multi-dimensional population data sets into personal predictive model to improve the continuum of the care for these women. And this is a scalable multi-omics platform. And very soon they are going to publish the paper and we'll understand more details on how they're working. So coming to the basic first day class of the Royal College, I want to come to this slide, which is whenever we change the practice, we always have to make sure that these basic medical principles are never forgotten, that we ultimately are looking after the patient-centeredness, utility, acceptability, autonomy of the patient to choose what they want to do. Always we try to tell them the options with pros and cons and let them decide and handhold them rather than telling them that we have decided something for them. Trust, transparency, justice, and beneficence, these are the values that we want to stick with whenever we understand something new and change our practice. And in future, we are going to have organoids, which is in the category of something called as super AI. So with so much tough data to be stored, there will be computer system built using human brain organoids cultivated from the stem cells, and this is signifying a bridge between the biological and artificial neural network. Starting from all those images right now, by January 2026, 25 million images with further more detail in each image were evaluated, and so much data will be coming and requiring the need for the storage. So we have to be aware of this. And this is an image from the journal from Neuroscience News. This is basically a laboratory cultured tiny human brain tissue organoid with the purpose to store data in the most efficient form. But obviously it's at a very, very early stage. So we may not have those huge data centers in future, and we may actually store data in something like this. So thank you so much, Dr. Divakar, for your kind invitation. And I'm happy to take the questions at the end of the session after my other colleagues finish. Thank you very much.
Thank you so much, Dr. Anu, for that brilliant talk, for giving us your insights on how artificial intelligence can help us in clinical decision making. Having listened to your talk, we feel now that the future is now and the future is here. Thank you so much once again. We now move on to the second talk for the day. We are delighted to welcome Dr. T. Ramani Devi, a distinguished clinician, academician, and leader in gynecology. A former president of the Tamil Nadu FOG and national vice president of FOXI, she has played a pivotal role in shaping endometriosis care and clinical practice guidelines in India. With decades of experience in numerous leadership positions in national and international professional organizations, Dr. Ramani Devi is widely respected for her contributions to women's healthcare and medical education. She will discuss the evolving evidence and practical considerations behind the growing preference for medical management of endometriosis. Before Dr. Ramani Devi starts, I would like the audience to start placing their questions, which will all be addressed at the end of the session. Over to you, Dr. Ramani Devi.
Thank you, Dr. Purni, for your introducing me. And I should thank Dr. Hema Divakar and the team for making me a part of this wonderful webinar. I think by now we have crossed nearly 960 people who are in the webinar. That's a great one. Thank you, Divakar, madam. Then let me share my screen. Are you able to see my screen?
Yes, yes, Ramani.
Okay.
Only full screen you have to. Yeah,
that's full fine, screen. Fine. It is a full screen. Okay. So that after a very, very nice lecture by my previous speaker, Dr. Anu, regarding what is going to be the future of endometriosis, it's mostly going to be AI-based. And now I just want to know, preliminary, I should say that why medical management is gaining preference in endometriosis over surgical management. I bring you greetings, my native place, that is Tiruchirappalli. You can see the beautiful river Kaveri and the rock fort, as well as the UNESCO accredited 1,000 pillars in Srirangam temple, as well as you may be wondering what is this painting. This is a painting from one of the churches in Italy, which that was somewhere in 18,000, where they have shown two young girls. You will see in the hip, there is a hip chain made up of thorns and acorns and apples are there, which are nothing but the symbol of endometriosis, where the girl suffers with severe pain and infertility. So endometriosis, by definition, everyone says there is a presence of an endometrial tissue that is abnormally placed. Then the prevalence it is highly prevalent, I should say. The younger age, the onset of symptoms, it is going to be very severe. And 25 to 40% of the infertile women, they suffer from endo. And 75% of the women with chronic pelvic pain, they have endometriosis. And I should say dysmenorrhea is one single important indicator in adolescent girls to say that she suffers from endometriosis. Worldwide, there are more than 246 million women who suffer from endometriosis. And India alone, we have 50 million. So I know everybody knows about the types of endometriosis. This phenotype is very important in planning our management, whether it is going to be a medical or a surgical. So now let us see what the learned society say. The American Society for Reproductive Medicine says that disease should be viewed as a chronic inflammatory disease that requires a lifelong management plan with the goal of only maximizing the use of medical treatment and avoiding repeated surgeries. So the treatment goal is we should alleviate pain, promote fertility, reduce recurrence, and improve the quality of life. So then 1 in 10 women, they suffer from endometriosis. And how do you diagnose endometriosis? Do we need a lot of gadgets or investigations to diagnose endometriosis? No. The simple history, clinical examination supported by imaging evidence, biomarkers will be the future because we can pick it up at a very early stage, trial of treatment, and there is no place for laparoscopy for diagnosis. The patient, I am very fond of telling it, the symptoms are 70s, dysmenorrhea, dyspareunia, dysuria, dystacia, dysfunctional uterine bleeding, diffuse abdominal pain, and difficulty in conception, everything leading to depression and fatigability. So this is a picture which shows all the clinical presentations. And again, it shows how it should be managed. The top priority is given to the pharmacology, physiotherapy, psychological therapy, and the surgery. And of course, we need to educate the patient, and support networks are very, very essential along with the lifestyle modification. Always we say that diagnostic delay is very high, maybe up to starting from 5 years to 9 years. But this picture shows what is the diagnostic delay in each phenotypic lesion of endo. So in ovarian, it can be 4 years. In deep endometriosis, it will be up to 7 years. In very severe deep ones, it can be up to 10 years, like nerve involvement. Adenomyosis, it is 9 years, and abdominal wall endometriosis, it is 2 years. Then again, based on the symptom, chronic pelvic pain, it might take 5 years to diagnose, dyspareunia, micturition, difficulties, and dysmenorrhea. And because most of the time, dysmenorrhea is being taken off as a normal part of menstruation. Then bleeding problems and infertility, because these women, they seek help earlier, soon after their marriage. So these are all varying years, like abdominal mass, maybe you can pick it up in 1 year, atypical lesions in 3 years. So all these things are differently expressed. Now, I want to say a few words about biomarkers because it has definitely a clear role in reducing the diagnostic time. Maybe it will be helpful in follow-up and monitoring the progress of the disease. Replace invasive diagnostic methods. Biomarkers could be considered clinically useful. And the criteria to say is it should have a sensitivity of 94% and specificity of 79%. Though Eshrey says that there is no role for biomarkers currently in diagnosis, but there are various faculties who are doing a lot of work in biomarkers so that it will be included in the next Eshrey. So imaging is the most common thing to diagnose endometriosis, be it an ultrasound and an MRI. And now let us see why the endometriosis should be treated medically. So based upon the symptoms, all the learned societies like the Eshrey, ASRM, ACOG, New Zealand, Australian and New Zealand Society, FOXY, then BFS, then Royal College and NICE, everybody is in favor of starting the medical treatment once when the patient complains of symptoms. So early and accurate diagnosis is the key to the better development. So now, which treatment is ideal? Do you want to take the medical management or do you want to take the surgical management? Over a few minutes, we can discuss which is ideal. The traditional surgical era was in the past, where it was considered as laparoscopy was considered as the gold standard in diagnosis and therapeutic management. And now see and treat is the philosophy. That is why surgery dominated. Because another thing is we did not have good medical options, and mostly it was an older drugs, they had their own problems, and we were not into specific targeted drug therapy. We did not have. So another thing is we needed diagnostic confirmation. So why now see why it is medical therapy is increasing? Because we have understood the pathology as chronic recurrent lesion, and the patient, they need a lifelong treatment, and they should avoid operative risk. and newer hormonal options are more practical for long-term use. Non-hormonal treatment is also gaining popularity, and treatment should be more precise and targeted treatment is more suitable. Then, why surgical decision is not preferred always? Because of the heterogeneity of the disease, pain and lesion doesn't match each other, fertility consideration, recurrence risk, ovarian reserve compromise, and multi-organ involvement. These are varying things which always we have to think before doing a surgical decision. Why not to consider surgery? Endometriosis being a chronic recurrent disease, here it treats only the lesions. But what is the basic biology is not corrected by surgery, and people may need multiple surgeries and recurrence is found to be very high. Hence, think twice before taking any decision. Now there is a diagnostic paradigm shift. The old model was symptoms, laparoscopy followed by treatment. But now the current model is symptoms, imaging, clinical suspicion, and empirical medical treatment is initiated. Again, ASRM, X-ray, ACOG, they have an individualized decision making. Surgery is not the first line. Consider the fertility goals, balance the benefit of retaining the ovarian reserve. Then prefer expert centers for surgery for DIE when not to operate. Because make a habit of two things to help, or at least do not do any harm. So, minimal disease with controlled pain, which is manageable with medical treatment, do not operate. Asymptomatic endometrium, no surgery. When fertility desired, especially in poor ovarian reserve, and when IVF is planned immediately, and lack of surgical expertise to handle cases of complicated cases. So the goals of medical treatment is, previously it was to suppress ovulation, reduce inflammation, improve the quality of life, delay recurrence, and preserve the fertility. So explore the effective pain relief. That is very important. Non-hormonal management is coming into vogue. Newer targeted drug therapy should be used for pain management. So the factors influencing the choice of therapy is because of the age, fertility desire, and then symptoms, severity of the disease, prior treatment, cost, side effects, and what the evidence says. Why medical management should be preferred? Because it avoids the surgical risk, minimizes the ovarian reserve damage, manages a chronic disease, prevents repeated surgery, and targeted pain at the source, temporary disease suppression. Then there was a timeline for medical management. We started originally in 16s with COCs. Then came the oral progestins containing medroxyprogesterone acetate, megestrol, etc. Then we have came dineges, and then came the GnRH agonist in 1990s, followed by antagonists currently. And now we are moving on towards the emerging therapies like personalized medicine, immunomodulatory agent. Of course, when the in selected patients in the early 2000, we have the insertion of this LNGIUS sperms towards management. And finally, we have for pain control, cannabis, polyethanolamide, and melatonin can be used. So there are newer drug therapies in the current era, that is GnRH antagonists, relagolix, and linsagolix, progestins and progestin antagonists, selective estrogen receptor modulators, and sperm. And now we have aromatase inhibitors, immunomodulators, anti-angiogenic drugs, which are non-hormonal, statins, estrogen receptor beta ligand. Why we should go in for a newer drug therapy? Because older drugs like COCs, progestins, and all these things, they had their, and even GnRH agonists, they had their own complications, like they were all contra-reproductive, and none of the drugs were able to be fertility promoting. So then now the drugs I have already mentioned, and now we have the targeted drugs which can increase the apoptosis, anti-inflammatory effect that can work against the ROS, and then they can reduce epithelial to mesenchymal transition can be suppressed, anti-angiogenic, and the endometriotic proliferation could be reduced, and most important is the suppression of neuroinflammation. Now, as I said, antagonists, elagolix, we have the LRS 1 and 2 trials, then which will definitely reduce dysmenorrhea. Not only that, it reduces the non-menstrual pain and improved functionality, but the limitation is bone mineral density concerns and the cost issues. In this way, elagolix scores over Dynagist, because Dynagist is effective only in 60% of the patient, and it is not good in reducing the non-menstrual pain. But the advantages start with Dynagist. Then suppose if the patient is not responding, maybe we can shift to antagonist. But again, Dynagist has been time tested, and there are a lot of studies to say that it can be used for a quite a longer time. Then came the relagolics combination therapy, which can avert the disadvantage of reduction in BMD, where relagolics combination therapy has got the built-in estrogen and the progesterone in it, and it has got an option of once daily and shows pain improvement over a period of 24 weeks. And now we have the spirit trial, which can be used for 24 months. Now let us see why the pathophysiology of pain is very important. Is all these agonists, they all act by suppressing the central level, hypothalamus, pituitary, and then ovarian level. But beyond that, the pain is there, and we need to suppress the pain, because we know that even after surgical correction, the pain is there, that may be persistent. That is because of the chronic inflammation, release of cytokines, neuroangiogenesis, where there is 14 times higher incidence of all the sensory nerve fibers. There is also a peripheral nerve sensitization because of the nociceptive and nociplastic pathway. Central sensitization is permanent, and there may be myofascial pain. Even with the small triggers, it can be amplified, leading to chronic pelvic pain. So the most important thing is we need to understand there are 5 important factors in endometriosis. One is expansion of the nociceptive field, brain morphology is changed, reduced pain threshold in these patients, decreased inhibition of the incoming signal, and hypersensitivity. All these things, surgery is not controlling the central sensitization. Beyond that, there are newer targets which can act against the inflammatory mediators, neurogenic pathways, angiogenic immune pathways, and ion channels. So this targeted therapy is going to be the need of the hour. Let us see what are all the emerging therapies. Like again, these things we have mentioned, and the second line is aromatase inhibitors, which can suppress the aromatase at the local level and at the peripheral level. And then we have advances in surgical technique, but they are available to only to few people. And then next is advances is gene and molecular therapies, because we know there are epigenetic changes which are the cause for endometriosis. So we can go through gene editing techniques using CRISPR, and then stem cell therapies and immunotherapy and non-pharmacological interventions are there. These are the list of drugs which can be newer drugs which can be used, and gabapentin is one drug which can suppress the central one. Let me say about the antibiotics sometime later. And upon the interventional pain management, physiotherapy helps a lot, because the buttocks pain, inguinal pain, leg pain, genital pain, abdominal wall pain, myofascial pain, pelvic pain, and all this can be improved by trigger point release, as well as giving a proper ganglion block and all the other handling the nerve fibers by suppressing it. Then the gut microbiota and endometriosis. Now we say gut is the sole thing for origin of disease. And here also we see this inflammatory bowel lesions are prone for endometriosis. Protective gut bacteria are lower, and we have lot of the streptococcus, E. coli, Gardnerella, all those things are increased in endometriotic patients in the gut, and there is reduction in the healthy bacteria, that is the lactobacillus. So we can treat these patients with metronidazole or with doxycycline. And again, concomitant use of these probiotics will definitely help to boost the gut protective microbiota. Then coming to the stem cells can be from the bone marrow derived or the endometrial stem cells. The theory suggests that dysregulated stem cells from the endometrium or other sources drive endometriosis development. It induces pluripotential stem cells. They can be again used for regeneration. What is causing the disease? By modification of these pluripotent stem cells, we can improve the outcome by promoting tissue repair, and it has got an anti-inflammatory effect, targeting mechanism. But there are certain challenges. That is, we have to think about the clinical hurdles, issues regarding the stem cell colonization and long-term efficacy, risk of tumor, and then storage. So the future Focus should be developing targeted therapies to correct the disease mechanism, improving delivery using stem cells as diagnostic marker. Then comes the gene therapy. Here again, this adenovector gene therapy has been initiated 15 years back. At present, several microRNAs that are aberrantly exposed in endometriosis, and by suppressing or upregulating, correcting the dysregulation of the microRNA, we can treat endometriosis, and my work is mainly on this microRNAs. Then comes the RDA1A mutation, which is found to be very high in endometriosis, that can be again treated with EZH2 inhibitors. So this tazemetostat acts only on RDA mutant cells. So this is from Hugh Taylor and group. Then indications for surgery. Though we say that medication is the most important one, there are certain places for surgery, because when you suspect malignancy, large symptomatic endometrioma, and whenever there is a bowel obstruction or a ureteric obstruction, or when there is failed medical management or fertility indication in selected cases, the surgery can be done. So, but it is not without problem, because it can lead to additions, ovarian damage, bowel injury, ureteric injury, bladder injury, and there is persistence of postoperative pain, because we are not actually dealing with the neuropathic pain. So then again, we have to think about the recurrence, which is around 20 to 40% over a period of 2 to 5 years, according to Sanvi's study, where he had followed the patient for almost 25 years. And the factors are, it could be incomplete surgery, and then severe disease stage, and young patients always recurrence is very high. And basically, as I said, we are not correcting the basic biology, biopathology. Then lifestyle modification is a must. So now let us take the adolescent. Always we say adolescent girls should be managed only with medical management. But there are certain exceptions when they are not responding to any type of medical management, or whenever they find severe in the larger endometrioma or die, where it affects the quality of life, then again, Mullerian anomalies are the ideal one in adolescent, where they should be treated with surgical method, because once when you correct the lesion, automatically the disease suppresses. And then emergency conditions like rupture endometrioma or recurrent endometrioma with severe pain, large size, and especially when it is suspicious of malignancy. Then preoperative decision factor is based upon the age, fertility desire, pain severity, previous surgery, AMH, imaging findings, and the surgeon's expertise. So the decision pathway is whether you need to do the pain pathway or the infertility dominant or mass dominant or deep infiltrating or a disease, a recurrent disease or an organ dysfunction. So here, pain pathway, very well, it can be managed medically. Infertility dominance, it is selected cases. Mass dominant, if it is going to cause organ dysfunction or recurrence, we need to think twice before we plan for surgery. And of course, in DIE, if at all you plan for surgery, it should be in a center of excellence. So in pain dominant pathway, when it is not responding to medical therapy, larger myomas, and all these things I have already mentioned. So when to avoid surgery in infertility? When the patient is immediately planned for IVF, smaller lesions, when asymptomatic, younger age, low AMH, and bilateral endometrioma, we have to go in for a avoid surgery. But of course, by doing surgery, you see the AMH level, whether it is a unilateral or a bilateral one, there is definite reduction in the AMH level over a period of 3 to 6 months and even 12 months. Though they say that there is slightly an improvement of the AMH level, practically we don't see, may lead to cystectomy is always preferred over cyst aspiration, because it reduces the incidence of recurrence. But we have to balance. Surgery should be done by a senior person so that we don't lose the ovarian reserve. So then, Yeshre, what they say about repeat surgery is, again, pain. Consider IVF instead of surgery. Fertility preservation should be discussed when you're doing it for the young girls. And rarely surgery may help in cases of failed ART. That also we have to think about. Then definitely surgery in patients have completed the family. Like once when they have completed, we can go in with the TAH, hysterectomy with or without bilateral salpingo-oophorectomy. Then again, organ compromise. So we need to based upon the images. Imaging is very important before planning surgery. And the surgical options are diagnostic laparoscopy versus therapeutic should be followed. Laparoscopy versus robotic surgery has got certain advantage, and we need to go for excision or better than ablation. And cyst aspiration versus cystectomy. Cystectomy is ideal, and dye excision, especially ICGU, should be there and done in a center of excellence. Nerve sparing surgery should be done. So infertility dominant pathway, generally stage 1 and 2, we don't know. By imaging, it does not pick up. Maybe we do a surgery, laparoscopy as a case, thinking as a case of unexplained infertility. Then see and treat policy. Then again, endometrioma, not as a routine, but if it is interfering with the pathway of your egg pickup, or if you feel it is quite large, maybe, or suspicious of malignancy, we can do it. And always hydrosalpingo has to be removed prior to ART. Dye selected patients in low AMH do not do. In recurrence of endometriosis also never do a surgery. So this is some of the guidelines by the early endometriosis. And then large endometriotic patients, we have to have a selected cases only, we should say, plan for surgery. So whenever we do a surgery, endometriosis fertility is one thing which should make, and this will help us to decide which patient should go for a spontaneous conception, whom should we select for early ART. Here, the score varies from 0 to 10. Less than 3, straight away ART. More than 7, her chances are very bright. And between 4 and 6, maybe we need to consider the other factors before planning. So these are the things given in the ESHRE guidelines. So for in the menopausal women, do we need to go for a medical or a surgical treatment? Most often, medical therapy, maybe the second line medical therapy like aromatase inhibitor can help. Or if the patient is keen about getting a total surgery, then we have to go in for a hysterectomy with or without bilateral salpingo-oophorectomy. Here again, I would say, even if you do a total surgery, it doesn't prevent you from getting recurrent endometriosis. Follow them with long-term therapy with the medical management. Of course, lifestyle modification is the most important one, and we should have a complementary, holistic way, including the physiotherapy, diet, stress-reducing one, acupuncture, yoga, mindfulness, calming the nervous system and lowering the stress. Future is AI-based. Role of biomarkers, non-invasive imaging, personalized treatment, patient-centered, non-hormonal treatment, targeted pain pathway combination should be used, and surgery should be carefully chosen, and we need clinical trials. So finally, endometriosis life, roots in utero, starts at 20, progresses at 30, problematic at 40, supposed to end at 50, malignant risk at 60, but needs a lifelong follow-up. To conclude, it is a chronic inflammatory disease. Repeated surgery should not be done. Central sensitization and persistent pain should be addressed. Modern medical therapies aim to suppress the disease activity, reduce inflammation and neuroangiogenesis, and hence they control the pain effectively, preserve fertility and ovarian function, improve the long-term quality of life. Personalized long-term medical management is needed. Surgery now plays a more selective role only when diagnostic difficulty is there, or organ distortion or obstruction, certain place in infertility, and refractory pain. So take-home message is the paradigm shift in endometriosis care, repeated excision to sustained disease suppression, and operating on lesions to managing a lifelong condition. Thank you for the opportunity given.
Thank you so much, Dr. Ramani Devi, for that brilliant elucidation about the medical management of endometriosis. You are indeed a great researcher, and we would like to congratulate you on your recent paper on the very same topic, the effectiveness and safety of Dynogest in Indian women. Thank you very much. There are already a lot of questions which have come in. Dr. Anu Chawla from London has agreed to stay till the end of this session to answer all of them. I'm sure many questions will be coming in for Dr. Ramani Devi as well. And the next topic is related to fertility, and because endometriosis is so closely related to infertility, I'm sure there will be many more questions on the topic as well. We move on to our next speaker. Our next esteemed panelist is Dr. Madhuri Patil, a leading authority in reproductive medicine and fertility care. She is the clinical director of Dr. Patil's Fertility and Endoscopic Clinic. President-elect ISAR Associate Editor of Fertility and Sterility and a founding leader of several national and international reproductive health organizations. Recognized with prestigious awards, including the Dr. Duru Shah Lifetime Achievement Award, Dr. Patil has significantly contributed to advancing fertility, science, and patient care. She will provide a fertility specialist's perspective on the challenges and opportunities in managing endometriosis among women seeking pregnancy. Over to you, Madhuri.
Thank you, Pune, for the introduction. And thank you, Hema, for inviting me here. So my topic today is specialist. And we know that it is characterized by presence of endometrial glands or stroma outside the uterine cavity. And we also know that it's a dynamic disease which defies understanding etiology as well as pathogenesis. And also we are aware that it is progressive, aggressive as well as recurrent, and therefore is a global health problem. And we also know that it compromises fertility. We've already heard Dr. Ramni Devi talk about the diagnosis, but I would just like to add on the non-invasive saliva microRNA signatures for endometriosis. And it has been seen that there are 89 microRNA signatures associated with peritoneal endometriosis diagnosis. And most important of these being the MIR 4421, 3153, 3974, 4632, 4674, and 6511A and 190A5P. And with this, the diagnostic accuracy is almost about 96%, sensitivity is 97%, and the specificity is almost 95%. So we can see, being non-invasive also, it has a good sensitivity and specificity. So if you look at the effect of endometriosis and fertility, it could be basically due to distorted pelvic anatomy, altered tuber milieu and transport, altered peritoneal fluid, faulty oocyte capture, autoimmune or immune dysfunction, sperm transport, and it can affect the sperm transport as well as function. And also it can result in dysregulated endometrial function due to estrogen dominance and progesterone resistance. It can also result in altered pituitary ovarian axis along with altered LH surge, and therefore it can affect ovulation. It can result in impaired folliculogenesis with fewer follicles being developed, luteal phase defects, and altered steroidogenesis with increase in the intracellular reactive oxygen species. So if you look at the ovulation, we know that there are fewer oocytes. There could be altered oocyte quality, as well as in these patients, the incidence of unruptured luteinized follicle is also significantly higher. And if you look at the fertilization, we know that there could be oocyte-linked reduced fertilization rates, poor sperm binding, and reduced sperm motility. It is also associated with poor embryo quality and early embryo arrest, with reduced uterine receptivity and altered hormonal regulation, resulting in decreased implantation rates. And during pregnancy, there's increase in the preterm loss, as well as it increases the risk of recurrent miscarriage. So we've already heard about the surgical techniques from Dr. Ramni Devi, and there are several papers which have been published, and they say that every touch to the ovary has a harmful effect on the ovarian tissue as well as on the ovarian reserve, and the AMH decrease was more prominent after bilateral endometrioma excision than unilateral excision, with higher incidence of premature ovarian failure. So then which treatment do we choose? Basically, this will depend upon the woman's age, the presence of severity of pain, grade of endometriosis, her desire for fertility, as well as need for treatment for infertility. But we know that there is no definite answer, and the therapy has to be individualized depending on each patient's symptoms, signs, and the pathology that is related to endometriosis. The aim, therefore, is to offer a simple, successful, and safe treatment to these patients. We've already heard Dr. Ramni Devi speak on surgical treatment, and it has been said that
if at all laparoscopy is done, and then it has to be operative where we need to do excision or ablation of the endometriotic lesions in stage 1 and 2 endometriosis. And this has resulted in increase in the clinical pregnancy rates as well as ongoing pregnancy rates. And this has a weak recommendation and a moderate quality of evidence. And it has been seen that the difference in the live birth rates in these patients in favor of treatment is about 8.6%, and therefore the number needed to treat is 8. That is, if we treat 100 patients, only 8 patients, then we are going to have 1 extra pregnancy. But then in 2022, the same guidelines said that it's very uncertain whether surgery improves fertility, and it had a grade B recommendation. So we've already heard about the correct indications for surgery, and this basically depends upon the age of the patient, her symptoms, the size of the endometrioma, her concomitant complicated presence of deep endometriosis, location or difficult transvaginal retrieval of the oocytes, rapid growth or suspicious features on ultrasound, and potential for rupture in pregnancy. And therefore, adopting a more conservative approach is essential in a case of asymptomatic patient, a patient who's older because she already has a low ovarian reserve, and also those younger patients where there is an established low ovarian reserve. And therefore, one must use meticulous techniques wherein we need to identify the right dissection plane. We have to have delicate maneuvers when we are dissecting. We have to avoid tearing of the tissue, and we have to do selective hemostasis where we do a water test and not use a lot of cautery, and suturing probably is much better than using cauterization. And this is because surgery can lead to reduction in ovarian reserve, basically by excessive stripping of the ovarian cortex at cystectomy, using a bipolar coagulation to stop bleeding, and also due to the inflammation that results from surgery. And if you look at the impact of, in this paper, which was published in 2024, you can, if you compare the impact of ablation versus cystectomy for endometrioma, it has been seen that after ablation, the weighted mean difference is 0.40 nanograms per ml. After cystectomy, it is much higher and is about 1.08 nanograms per ml. The intergroup difference favoring ablation is about 0.38 nanograms, and therefore cystectomy drops the AMH approximately 2.7 times more than the ablation, and this was seen after a follow-up of 3 months. And if you look at the recurrence, the overall recurrence rate is significantly higher after ablation because we are causing lesser destruction of the tissue, and even 1-year recurrence rate is again significantly higher with ablations. But if you look at the pregnancy outcome, there is no significant difference between the ablation ablation group as well as the cystectomy group. And therefore, we can say that ablation preserves more ovarian reserve, but at the cost of high recurrence rate. And probably using a laser as compared to a bipolar coagulation is much better because it results in lesser damage, as there's a lot of tissue sparing. It has a better thermal control. It's very precise. It has less detrimental effect on the adjacent healthy ovarian tissue. It's also simple and easy to use, reproducible, and it can work in difficult to reach areas and tight spaces much easily than a cauterization. And therefore, the ESHRE guidelines said that we must consider operative laparoscopy as a treatment of endometrioma-associated infertility, as it may increase the chance of natural pregnancy, although there is no data for comparative studies that exist. But it has a very, very weak recommendation and a very low quality evidence. And again, the evidence says that probably laparoscopy for deep infiltrating endometriosis may improve fertility in symptomatic patients, but this also has a very low quality evidence and a weak recommendation. So basically, the most appropriate recommendation is that The decision to perform surgery should be guided by the presence or absence of pain symptoms, the patient's age, the history of previous surgery, presence of other infertility factors, the ovarian reserve, and also the estimated endometriosis fertility index, which Dr. Ramani Devi has already spoken about. And therefore, it's important to assess the need for assisted reproduction after surgery. And therefore, these women should be counseled of their chances to becoming pregnant after the surgery, because we really know what transpired during the surgery and what problems were associated and whether the tubes were affected or not, and what was the tubo-ovarian relationship. And therefore, we need to identify patients that may benefit from ART after surgery. And this depends upon the endometriosis fertility index. And we also need to look at the other fertility investigations, whether they are normal or abnormal. And most important is taking into account the semen analysis report. Coming to the medically assisted reproduction techniques in these patients, wherein let us look whether IUI with controlled ovarian hypostimulation is helpful. And it is if the total motile count is more than 5 million. And usually the cycle fecundity rate is about 15% when controlled ovarian hypostimulation with IUI is done. That is, here we are using gonadotrophins with IUI and not oral ovulagens. And if you compare that in those patients who did not undergo IUI, the pregnancy rate was only 4.5%. And therefore, there's almost a threefold increase in the live birth rate in patients who have stage 1 and 2 endometriosis. And this has a very good evidence of A. The cumulative live birth rate with IUI with controlled ovarian hypostimulation has an odd ratio of 5.6, which is significantly higher if IUI with COS is used. And it has also been seen that the paternal obesity contributes to infertility, while the elevated maternal BMI increases the medication requirement without impacting the pregnancy outcome. And if you look at the use of various ovulation induction drugs, both letrozole and clomiphene citrate have similar pregnancy outcomes, but gonadotropin has better pregnancy rates, but it also has a higher risk of multiple pregnancies and also a higher risk of developing ovarian hypostimulation syndrome. And according to the ASHRAE guidelines, they said that probably IUI with ovarian stimulation instead of expected management will increase the pregnancy rates, though it was a weak recommendation with a very low quality of evidence. And they said that in the presence of tubal patency, it is uncertain whether it is helpful in increasing the pregnancy rates. Coming to IVF, we know that it is indicated in those patients who have decreased ovarian reserve. If the age of the woman is more than 37 years, she's married for more than 5 years, or is trying to conceive for more than 5 years, she's had several failed control ovarian stimulation and IUI cycles, recurrent endometriomas, bilateral endometrioma, and if endometriosis is associated with adenomyosis, or she has a bilateral tubal factor or a male factor. Certain concerns when we do one is that associated with the ovarian response and less oocyte number. We are not, because there's a controversy in using the protocol in these patients. The quality of the oocytes could be affected. Then again, there's a controversy whether we should do a fresh or a frozen transfer. And if you're doing a frozen transfer, whether we should downregulate the patient or not, whether we should do a surgery for endometrioma prior to IVF or not, whether any medical treatment is going to benefit the patient in improving the pregnancy rates if used before IVF. And also need to look at the reproductive outcome in these patients. So if you look at the ovarian response, we know that it is associated with lower response with higher dose of gonadotrophins, and poor response is seen in almost 27% of the cases. In women with unilateral endometriomas undergoing IVF, ovarian responsiveness to COS did not markedly differ between affected and intact gonads in women carrying small unilateral endometriomas. The ovarian responsiveness was significantly associated with the size and number of the endometrioma, and reduction in the ovarian responsiveness could be observed only in the presence of large cysts, which are more than 5 centimeters, and in those who have bilateral cysts. Poor response to ovarian stimulation, even if the fertilization rate and quality comparable to unoperated ovaries, for whether operate or you operate, the incidence of having high quality embryos does not decrease. The most important is that we need to choose the right dose of gonadotrophins, and this will basically depend upon the age of the patient, the ovarian reserve, that is both the antifollicular count and AMH, the BMI, as well as the response to prior stimulation regimes. And the initial dose, what we could use could be anywhere between 225 to 300 international units. The dose is then adjusted according to the response of the ovarian follicles, which were followed up via a transvaginal ultrasonography. There's no evidence for preference whether we should use FSH or HMG, recombinant or urinary preparations. Again, whether we should use agonist or antagonist, though initially in the 2013 guidelines, it was said that long-term antagonist for 3 to 6 months before IVF-ICSI probably improves the results. But today, there are several papers, the Cochrane review, as well as the ESHRE guidelines say that long-term GnRH agonist therapy before IVF for improving fertility outcome has uncertain benefit, and therefore we could now use an antagonist protocol. Basically, you can see over here that using both agonist and antagonist protocol have had similar pregnancy rates and also similar live birth rates in various studies which have been published. We could have low number of oocyte recovery due to technical difficulties at oocyte retrieval due to ovarian adhesions. Ovarian endometriosis can also affect the follicular recruitment. Apart from aspiration of the oocytes, the cytokine specific to the endometriosis can affect ovarian response to medication. And we have seen that the poor response is seen in about 27% of the cases. It has also been seen that increased oxidative stress, cell cycle dysregulation, inflammation, and impaired angiogenesis can decrease both the oocyte as well as the embryo quality. And if you look at the pregnancy outcome in freeze-all versus fresh embryo transfers, though this paper in 2025 said that FET yielded better or higher clinical pregnancy rates, live birth rates, and implantation rates, this paper, which was published in this month in 2026, has concluded that FET does not confer a benefit over fresh embryo transfer for improving the live birth rate or reducing pregnancy complications in women who have ovarian endometriosis, and therefore fresh embryo transfer is a viable and potentially more time and cost efficient option in this patient population. So is surgical therapy required as an adjuvant to medically assisted reproduction? And the answer is no, because there's a strong recommendation that one should not go for any surgery, maybe stage 1 or 2 or 3 or 4. And even in the presence of endometrioma, and basically it should be only reserved for those patients who have endometriosis associated pain, or there is a problem in accessibility of the follicles during the oocyte aspiration. And if you look at the surgical excision of deep endometriosis, again, it should be guided only by the pain symptoms. Otherwise, surgery for the same does not improve the pregnancy outcome. We have already seen that, and this is very clear in this forest graph that whether we use an agonist or antagonist, it is really not going to affect the number of oocytes retrieved, the fertilization rate, the embryo formation rate, blastocyst formation rate, implantation rate, as well as the pregnancy rates. So let us look at certain pre-medical treatments before IVF. So does Dynogest pre-treatment affect the outcome? But it has been seen it does not either improve or worsen the treatment. However, it provides pain controlled relief before undergoing IVF, and there was no significant difference seen both in the clinical pregnancy rates or the live birth rates as a primary outcome. And also there was no significant difference seen in all the secondary outcomes, which included the number of retrieved oocytes, the mature oocytes, the blastocysts formed, and the transferable embryos that were obtained. We have already seen that there are three basically oral antagonists which have been used, but it has been shown that none of these are licensed to be used during fertility treatment, and it has also been shown that it probably does not improve the success rate or the reproductive outcome in patients who are subjected to IVF, but they are definitely helpful in those patients who have adenomyosis but not endometriosis. Dr. Ramani Devi has also talked about the microbiome, and therefore probably targeting the microbiome may probably be a future treatment modality for infertility in this group of patients. And if you look at the ESHRE guidelines, they said that that IVF should be performed in patients who have their tubal function compromised in the presence of male factor when the EFI score is low, or if there's any other treatments have failed. Both agonist and antagonist protocols are good enough, and it has been seen that ART is safe and it does not increase the recurrence of endometriosis in this group of patients. And in patients who have endometrioma, antibiotic prophylaxis is a must after oocyte recovery, and FET strategy is probably associated with a favorable outcome. But this was in 22, and we have seen the 26 paper, which says that it does not make a difference whether you go for FET or a fresh transfer. Coming to fertility preservation, it's a strong recommendation that if you have extensive ovarian endometriosis, we have to discuss the pros and cons of fertility preservation, though its true benefit is unknown in this group of patients. We also need to look at the cost effectiveness, because we know they have to pay not only for preserving their oocytes or their embryos, but also for storing them for whatever time period they want, and probably may be helpful in those patients who have large endometriomas with low ovarian reserve. And therefore, a proper counseling of these patients is very, very important. So if the reproductive outcome, though initial studies have shown that it has a detrimental effect both on the pregnancy rates as well as the implantation rates, the most recent study, which was published in 2024, has shown that though the implantation rate, as you can see over in this forest graph, is significantly lower, there is no significant difference in the live birth rate, the clinical pregnancy rate, as well as fertilization rate. The implantation rate may be low probably because endometriosis promotes progesterone resistance and estrogen dominance in eutopic endometrium. And this progesterone resistance results in inadequate antagonism of estrogen action, increased inflammation and defective decellularization, leading to a non-receptive endometrium for embryo implantation. There is no clear picture when, where, when, and how progesterone resistance develops in these patients. And therefore, if you look at this paper, which was published in 15, you can see that there's no difference in stage 1 and 2, because the live birth rates, clinical pregnancy rates, and the number of oocytes retrieved are almost similar. But stage 3 and 4 is definitely associated with lower live birth rate and clinical pregnancy rates. We have also seen that endometriosis is associated with increased incidence of early pregnancy loss, ectopic pregnancy, greater risk of gestational diabetes, as well as hypertensive disorders of pregnancy. It's also associated with decreased fertilization rate and decreased M2 sites being retrieved, miscarriage rate, as we have seen, increased risk of preterm births, placenta previa, cesarean section, and hemorrhage, as well as with increased neonatal admissions. And all these, most of them are all recent papers. And basically, the explanation for these complications or adverse pregnancy outcomes is progesterone resistance, altered contractility, which results in deferred implantation, Increased ROS, alteration in the uterine junctional zone and inflammation results in shallow invasiveness, and this can then result in preterm birth, whereas deferred implantation can result in defective placentation with IUGR. It increases the risk of miscarriage, spontaneous abortions, and recurrent pregnancy loss, as well as placenta previa. So does it increase the progression or recurrence? And the answer is no, because as you can see over here, it does not increase the recurrence, and all of them have a moderate quality of evidence. And it also does not increase the incidence of ovarian endometriomas, though some papers have said that IUI may increase the risk of endometriosis recurrence, and deep invasive endometriosis might progress with ovarian stimulation. So I would end with the following take-home messages. So today, laparoscopy is no longer the gold standard. We have the transvaginal ultrasound and MRI, which needs to be used. We have different options that we can do. There is no evidence, and it's not effective to give hormonal treatment before when the fertility is desired. Surgery may be effective in restoring fertility in certain cases. We have to look at the EFI EFI, which is whether the patient requires assisted reproduction or spontaneous conception. And as we said, that if the EFI is more than 7, natural conception is possible. If it is between 5 and 6, IUI may help. But if it is less than 4, you require that this patient goes for IVF. And when it is done, when medical assisted reproduction is done, basically stage 1 and 2, we can go for 3 cycles of control ovarian stimulation with IUI, and if there's no pregnancy for IVF. And when in stage 3 and 4, probably IVF with GnRH antagonist protocol basically is the treatment of choice today. The dose of gonadotrophins depends upon the ovarian reserve, and one must counsel the patient that IVF is not very effective when the disease is more severe. So what are the points from this talk? Endometriosis remains one of the most perplexing diseases for patients, physicians, and researchers. Incomplete understanding of the etiology of endometriosis makes defining its association with infertility a challenge. Therapies for endometriosis are controversial because they can improve, because they may or may not improve pain and fertility, but they do not cure the disease. Endometrioma and its surgical treatment decreases ovarian reserve, which is irreversible, and routine surgery before IVF is not recommended. Endometriosis per se is associated with decreased oocyte quality in IVF cycles. Agonist or antagonist protocols have similar reproductive outcomes. And today, a long GnRH agonist protocol is not recommended. And in endometriosis, conceptions with or without IVF are associated with increased obstetric risk. And therefore, one must individualize the risk and benefit and then treat these patients. And fertility preservation counseling may be necessary in some of these patients. And I thank you all for a patient hearing.
Dr. Madhuri Patil is known as the walking, talking encyclopedia, and now you all know why. Thank you so much for that brilliant talk, ma'am. It was indeed a privilege to have you as a faculty today. I now hand over to Dr. Hema Divakar to carry on with the Q&A session. I'm sure there are a lot of questions for all the panelists. Over to you, ma'am.
Thank you, Purni, and thanks so very much to all our distinguished speakers. The delegates have immensely enjoyed, and they have complimented and congratulated all 3 of you for the brilliant talks, wonderful slides, etc. So that is the first thing I want to place on records. And I think do or die. When I was talking about terminologies, die also means deep infiltrating endometriosis. So, it is such a complex thing that we really needed these brilliant speakers to just threadbare, dissect out a lot of nuances in this topic. So we are now going to go on a rapid fire because there are many questions, and then we would love for all those to be answered in the shortest possible time. So the first question was from Dr. Hemant Bhatt, who has actually followed it up with another question. So I'll read both his questions one after the other. It is criteria to start infertility treatment for patients with endometriosis. When do you start it? And his other question was actually, when do you start after giving elagolix for the treatment? When can you actually, here it is. After giving Dynogest and elagolix, when to start infertility treatment? So these are his two questions.
Yeah,
Madhuri?
so you want me to? Yeah. So basically, as I said, that elagolix, that is the GnRH antagonist, are basically not advocated as a pre-treatment in ERT still. They have not been approved. So basically in adenomyosis, if we give them, we can give them for 3 months. And after that, we can go ahead with the treatment in patients with adenomyosis, because it's been tried in small studies, but in endometriosis, it has not been tried. But again, there are no randomized control trials. So therefore, we can say that there is no evidence still in using these drugs as a pre-treatment before ERT in this group of patients.
Right.
Probably with the Dynogest, once you give, because it's a progesterone,
Mhm.
so it's best that you wait for at least one cycle, because the progesterone level should come down. Because many a times if the progesterone levels are high, then it can affect the maturation of the endometrium and therefore reduce the endometrial receptivity. And if after one cycle, probably you can wait. And we normally would do the progesterone levels on day 2 before we start the stimulation. And it has to be less than 0.8 to 1 nanogram per ml, along with E2, which has to be less than 50. Then only we would start the treatment. Because if the progesterone is high, we would not start the treatment.
If so many things have to be paid attention to, it's very clear to the routine OBGYNs that we need to refer to super specialty within our specialty for all the fine tuning that needs to be done, because much has been talked about individualized and precision driven treatment. Nazran Gaya, thanks Madhuri. Nazran Gaya asks, this question may be to Dr. Ramni Devi. Should we still prescribe Dynogest as a treatment option for severe dysmenorrhea in young unmarried girls where minimal access surgery is evolving fast? What would you choose for them?
I think it is a very good question, because the moment antagonist had been pumped into the market, we forget the ideal drug, that is the Dynogest, because definitely in young girls, we need to use the drug for quite a long time. And we have evidences even that this research study was saying that you can use it for almost for 5 years. They have done the trial, and then now we have studies even beyond 7 or 9 years. And it is very quite safe. The BMD reduction is not much. And of course, only 60 to 70% of the girls, they will respond to Dynogest. That is because that truncoles definitely the dysmenorrhea, but non-menstrual pelvic pain is not handled. So it is only in that situation we need to shift to GnRH antagonist. But still, I feel the first line of choice is only Dynogest.
Right. Thanks, Ramni. Rajeshri Palladi has asked a question. Any role of Fusbacterium infection as a causative factor for endometriosis?
Yes, there have been studies by Ramakrishnan et al. He says that Fusbacterium and a lot of this E. coli, even E. coli, Streptococcus, then Gardnerella, all these things are known to cause endometriosis, gut dysbiosis as such. And there will be a leaky gut, and then they can have increased ROS, and all those things will definitely lead to endometriosis onset.
Right. So that is probably
That's a part of the one of the etiologists, they say. No?
So Vidya Gayatri has asked again, I think this is because, the large mindset shift from surgical to medical has caused a lot of, queries in the practitioner's mind. So the question again by Vidya Gayatri is, how long elagolix can be given and what are the side effects?
See, at present, elagolix, to say, I attended the international conference at Frankfurt, where they said they are not using elagolix in European countries. They have now shifted to relagolix and linzagolix. The main reason is the side effects. That is, it causes definite bone marrow reduction, and always we need to have a separate add-back therapy. But as on date, the trials, that is ELARIS EM1 and 2 trial, it says that you can use it safely up to 2 years. Then again, it is in a dose-dependent way. Maybe the only advantage I find with elagolix over elagolix is that it is dose dependent. In severe cases of deep infiltrative endometriosis, we can start from 200 milligram BD for some time. Then if the pain is under control, you can switch back to 150 milligrams. That the dose flexibility is possible with elagolix, but there are no studies to say that it can be used beyond 2 years. But as far as relagolix is concerned, this side effects like vasomotor changes, BMD reduction is not there. So, but again, here the studies, the duration is quite limited.
You mentioned elagolix and went on to comparing it with relagolix. There's a question from Sonal saying relagolix gives excessive hot flashes. How to resolve this problem?
Elagolix. Elagolix or relagolix?
She's asking about relagolix giving hot flashes.
Relagolix, because of the built-in add-back therapy, I think you should not have hot flashes. And the studies, that is the SPIRIT trial as well as the Liberty trial, which was used for the leiomyoma, says less than 5 to 10% of the patient, they do suffer from vasomotor changes when compared to placebo. Or, of course, when in the study, there were 2 arms where they started with the add-back therapy right from the beginning. And in one group, they started plain relagolix for 3 months, then switched over to add-back therapy. So the main thing is in the early period where they did not use an add-back therapy, probably they would have had vasomotor changes.
Yeah, I agree. So Varsha Singh asks, for how much duration of medical therapy can you then declare it's failure of medical management?
I think
after what duration you'll say, now I give up.
It is quite a difficult thing to answer because it depends, as I said, it depends upon the phenotype of the disease also. Variable phenotypes, variable symptom presentation. So if the patient has got symptomatic relief within 3 months, then probably she is an ideal candidate who can be continued on medical management. And again, I tell you, there is a hitch. We can use combination therapies. Because GnRH antagonists and dyneges all are acting only at one pathway of pituitary downregulation. But there are certain other factors like, as I said, that targeted mechanism that can also be added. For example, you can combine always anti-angiogenic drugs. Gabercolin can be combined. And then palmitoyl ethanolamide, now they have come out with a lot of referrals to say that it can be used as an adjuvant. Curcumin and all those things. In advanced cases, probably we go for an immunomodulatory support. Like they have given even tumor necrosis alpha inhibitors can also be given. So I think this has to be individualized. Start with one drug, not responding, maybe you can go in for a combine. And one thing is, I have found out in patients who are having adenomyosis, the combination of antagonist or agonist with letrozole gives the best effect. Because aromatase inhibitors, because again, we need to understand aromatase inhibitors act both at the central level as well as at the peripheral level. And each endometriotic tissue has got an aromatase activity is enhanced that can also be suppressed. So they definitely get good relief with combination of this analogs with letrozole. And in adenomyotic patients, I feel it's an excellent drug to reduce the volume prior to ARTs, transfer of embryos.
Yeah, thanks. Andu, the question to you, within the FIGO circles, now we are going to be giving us the recommendations for early diagnosis of endometriosis, what to do, what not to do, a stepwise, pattern, so to say. In your part of the world, London, is elagolix, relagolix, in lot of views as how so many questions are being asked, and is there a lot of confusion or clarity, or what's the status there?
Yeah, a lot of drug companies in the last 2 months have asked me this question from India as well. So I'm aware of the huge difference in practice. Dr. Ramni Devi already mentioned that she already had this experience in Frankfurt. So I would actually say we are on the same line. So we are very concerned about the downregulation, which is very important in this age group. of women. I wouldn't want any of my young reproductive age group woman who is yet having another 50, 60 years of her life pending to have lower bone marrow density or cardiac issues or something. So we are basically doing a medical oophorectomy for some time, and we don't know the long-term implications. So we are very scared and worried of the long-term implications despite the add back.
Yeah.
So we don't know what is the degree and how much is the suppression going to stay even after we stop the medication. So we use Dynogest. We do not yet use antagonist for the medical management of endometriosis at all.
I think in India, whatever drug comes, all of us just hop in to use it, I think. And that's the reason why the antagonist and even the GLP-1 agonist are used in numbers, though there's not much evidence, though they said that only the endocrinologist should prescribe, but we see that even
I
gynecologists
agree.
are prescribing.
Because there are so many questions on this, I'm wondering, like, how many are using, how many are still, at the crossroads of to whether to use, when to start, when to stop, why and why not. There really seems to be snowballing the questions. That's why I flipped that question to Anu, because we need to be cautious, guarded about everything else, even about the GLP to semaglutide. I was saying, as gynecologists, we should not hop in as the first prescribers because we need to learn so much more about it. It's really not our forte. And how much can one person in one lifetime and in one of practice, with the overwhelming. So we should be do no harm. Should again come back to us in a very big way, in a reflective way, before penning it down. Yeah.
Australia has banned the use of GLP-1 agonist, actually,
Yeah.
because they reported several complications with that.
Like
Yes.
thyroid cancer, like pancreatic cancer, like how am I as a gynecologist supposed to prescribe? I don't understand. So we don't. Yeah.
Absolutely. And now Suman Singh is asking a question. I'll read out the question as is. Can a patient become pregnant while taking elagolix or relagolix? Probably not, she says. Then how should she plan for her pregnancy?
See, there are few articles to say that pregnancy has happened with the low dose elagolix. So they have given the caution that they should use some contraceptive. Okay, so that is that early thing that was given. So probably, Anu wants to say something.
No, you complete and then I'll add.
Okay, then I think it is always better to stop elagolix and then plan pregnancy after. So though they say that ovulation returns immediately after stopping antagonist, it is better they wait for at least 2 or 3 months, then plan their pregnancy.
Right. Can aromatase inhibitor and elagolix be combined? Before that, Anu can just add.
I just wanted to add one experience I had in 2014 and 15 when I first went to New York to John Zhang's clinic, and he was using elagolix as the oral antagonist, and he was marketing as a needle-free IVF. Even in the New York subways, he had put the marks of needle-free IVF at New Hope Clinic. So he was using elagolix for fertility treatments as an antagonist. So it's not a problem if the patient is pregnant. We immediately just have to make sure that she's not, if she was on a significantly long term, she wouldn't get pregnant anyway. So if she was on elagolix for a long time, it's unlikely she will get pregnant. But if she was on elagolix for a very brief time and she's got pregnant, we just will monitor the pregnancy. There's no need to do anything more than that.
Yeah, so now the combo, Madhuri, aromatase inhibitor and elagolix, as if one was not enough. Now we got the question to make it more complex. Gauri, Kumra.
Basically, elagolix should be used. If it's used in patients of infertility, it is used to prevent the LH surge, and therefore it is basically used only in ART patients. Whereas aromatase inhibitors are used as oral ovulagens and they're used in non-ART cycles rather than in ART cycles, except in patients who are undergoing fertility preservation for breast cancer, who are ERPR positive, where we give aromatase inhibitors, and there's no role of using elagolix. So I don't think a combination is normally used also.
Yeah. And again to Anu, the role of biomarkers, which is a specific one that I will direct to Dr. Amni Devi. But before that, you said many criteria the AI will take in as age and other things. So does it also include the biomarkers? Is it included in the
Yes.
list?
So yeah, it was a part of my presentation that
Yeah.
basically the single cell transcriptomics
Mhm.
will actually tell us how within endometriosis there are different categories of lesions.
Hmm.
So we may have newer classifications of endometriosis telling us that this is actually a different disease altogether, but looks like endometriosis, or how they are contributed within the same lesion. So it could be epithelial, stromal, or immune cells contributing to that
Who is
lesion.
talking? Who is whispering? That.
Yeah.
Yeah, exactly.
Yeah.
Yeah, that
Yeah.
slide.
Okay.
So that basically will tell us how to develop the biomarkers more specifically, and it's all already being done with the help of AI. I mean, it's going to make everything so much faster.
Oh, okay. So, Ramli Devi, again, role of biomarkers, which specific one? Biomarkers for endometriosis. Ganga and one more anonymous attendee has also asked the same question. Are we already recommending a specific biomarker for endometriosis?
See, in Yeshrai guidelines, they are giving, there is a role for mRNA as a research thing, not on a routine clinical practice. But how do we get our routine clinical practice unless we produce more and more of research papers and then come to a conclusion? So as a preliminary thing, I have done my microRNAs like similar to Professor Phillips Destin, that same microRNAs, we selected 6 of them. And then instead of saliva, we have done it in serum because initially we tested that salivary was not stable in our temperature. That problem we had. So we had done it with the serum. And the initial part of it, I have compared with 120 cases of proven endo versus proven non-endo. We could get a very good AIC curve with a sensitivity and specificity of beyond 90%. Then our next step was what we did in adolescent girls, young patients, presenting only with progressive dysmenorrhea, not going to the school absenteeism or work absenteeism. I caught hold of these patients and we did this microRNA study. And when they were found to be dysregulated, I started them with dionysus because every society is for empirical management of endometriosis. But even in that, some of the patients, they wanted a diagnostic lab before going in for starting the treatment. So when I did the laparoscopy for such patients who requested, I could find very early endometriosis because all these adolescent girls, they did not have any imaging evidence. So that was one thing. So now we are trying to work more and more in this adolescent girls where we can confidently say that this patient is likely to suffer from endometriosis based on the symptoms. And our important symptom was dysmenorrhea 1, and in sexually active young girls, dyspareunia was the second point.
I think this beautifully fits into our life course approach of FIGO, that we say even at adolescence, early detection, early diagnosis, get them on to prepare for the next phase of their life. Don't miss the opportunity. So I think there are more exciting times going to be ahead of us with our own evidence produced from the country. We are so proud of that. As Purni said, that research is not easy and it's not everybody's cup of tea, but we are so happy and proud that many champions in the country are supporting with bringing up the data and documenting the evidence so that we can be more precise in actually offering the best to our patients.
And again, one second. See, this Bendifala study on AI, he has included only the same biomarkers. Okay, so apart from the history, imaging findings, plus the biomarkers and the surgical findings, all are put together in the AI.
Right. So, that is because like how now we are saying PLGF for preeclampsia, eclampsia. So one biomarker, bedside test, point of care test, it's slowly emerging. So I think it'll all, as pieces of the puzzle, it'll all come together to solve the problem. Tejavati says very clear indications for surgery and various options available. Was very well explained by Dr. Ramni Devi, so they're very happy.
Thank you so much.
That
Thank you.
Parimala says just all the slides were superb. And Tahira says how important and whether we can decide the severity of endometriosis by rising levels of CA125.
No, it's very insensitive for that.
Yeah.
So we can, so the typical feature of the whole pathology itself is that the symptomatology is not directly proportional with the stage of the disease, first of all. So that's why you don't have to have rising levels of anything to have worsening symptoms, because somebody with stage 1 may have very bad symptoms and somebody with grade 4 big endometrioma may never know. So this is a difficult one. At the same time, although we have markers, but we don't have the commercial labs who can give us the accurate reports yet.
Yeah, so imaging, the symptoms and imaging and AI and biomarkers, everything will, when it's tied together, I think we'll get more closer to figuring out things earlier. Yes, Ramni?
I would like to add up one thing.
Please.
CA125 is non-specific, but it can be used in follow-up. But sometimes the increase in the level of CA125 is so alarming, we have to think not only of malignancy, but rupture of endometrioma. Patient coming with severe pain, showing very high levels of CA125, don't immediately think about malignancy, because in malignant, I have seen in rupture endometrioma, the CA125 levels are beyond 3000. So we need to go back by the history, because that young patient giving history of progressive dysmenorrhea, having a mass, and suddenly complaining of severe pain, the general condition is not cachectic. Always think about rupture of endometrium.
But if such a bad symptomatology happens over a short period of time, that qualifies for the surgery itself.
Surgery is indicated. Yes.
So there's no. So I mean, I wouldn't. Again, so follow up, yes, follow up. Yeah, I'm sorry, I said specific. It is non-specific. It is very sensitive, but it is not specific, and it's good for follow-up, but never good to gauge the intensity of the problem itself. And if the rupture or something like that happens, that person should not be denied for a surgery.
Yes. Yeah.
I mean, it's so large.
Which with what Anu tried to say was it can be bad endometriosis, but with normal CA125.
Yeah.
Just minimally raise CA125. That is not all, not necessarily correlating or proportioning.
Yes. And then when we do surgery, we anyway take the biopsy. So we will know exactly histopathology.
There is one thing that Dr. Shobha Gudi says, maybe she is our future leader, so she may take this ahead. Can we take a special training dedicated only for endometriosis surgery in centers of excellence? Yeah, so I think because DIA and all, it was already specified that some experts have to do. And then also we have to have the maturity to refer to the experts. Because sometimes, the routine OBGYNs or laparoscopic surgeons, we just go in and try to do things, and it's not in the interest of the patient. So I think we should think twice, as how it was given in one of the slides, that really think twice before, because some of these complex issues will really call for a rethinking. Madhuri Madam, the question from Pavitra Balakrishnan. She says, Madhuri Madam, rate of ectopic after embryo transfer due to endometriosis. I think you already mentioned in your slide, but you can say
it's about 2 to 3% higher.
Yeah.
Than the non-endometriotic patient. So it may be anywhere between 2 to 3.5%.
One question about oocyte quality in endometriosis that I think you've more than
elaborated. That is controversial, though it is controversial, because some papers said that it does affect, and then when they compared it in a randomized control trial with donor oocyte, they said it does not get affected. But in my experience, it's definitely affected. The oocyte quality is definitely affected in patients with endometriosis.
Sure, they're already
the best author on this subject is Paul Pertia from Paris, from France. So Paul Pertia has heavily published on this particular question, infertility, sterility, multiple times recently, starting from January 2021. He has massively been published. And his outcome is that as long as you have a euploid embryo, it doesn't matter.
Yes.
And that is my experience also, which is different from my seniors.
Sure. So Lavanya Kiran says, great talk. And as I said, Shobha Guri says we should really go in depth into this topic because there's so much to understand before just, prescribing right, left, and center. We may be really causing problems to the patient is what I gathered because I'm in awe of these great talks today because there's so much to learn and it's exciting to know that learning never ends really. Parul Sate says prerequisite blood test before starting relabolics.
I think, probably I think they would want to know whether we need to have a check upon the bone mineral density. Because routinely for any patient, we'll be doing a basic CBC, her renal function test and glycemic profile, etc.
So BMD with DEXA we have to do?
Yeah, that's
Not
right.
that foot
But
to test.
No, I don't think we need a routine DEXA scan for assessing this BMD prior to any treatment. We don't do it.
Okay, the other BMD mission where we just keep our foot is not.
That's not good, madam. What they check with the foot or anything.
Okay.
That's not good. DEXA is ideal.
Okay. And then also add back therapy only with calcium is Sarita what she's saying? Is that
No, I usually start with calcium and vitamin D3. On long term, preferably I add up with the alendronates.
Yeah.
Because that helps.
Yeah.
So the patient will.
So bone health has to be kept high in our mind.
Yeah,
agree. Tejavati again says less hot flushes with elagolix. That's what you said as well. Dr. Vijay Lakshmi Sheshadri says postmenopausal endometriosis with high risk for pre-malignancy. Does medical therapy still okay? Or what should we do?
No.
That I think we need to go in for an imaging. Imaging is very important. Then you rule out the other investigation. Here, I would like to add up one more thing. More than the malignancy, in the postmenopausal women with endometriosis, we have another huge problem of cardiovascular disorders and cerebrovascular disorder. Because, see, it is an inflammatory disorder, and where there is atherosclerotic changes are seen even in the young patient in their vessels. So the same is reflected on the coronary vessels as well as in the cerebral vessel. So we have to tell them, keep them like under monitoring regarding these two. They have found out the incidence of myocardial infarction, stroke, and all the metabolic problems are higher in the postmenopausal women with the endometriosis. The reason could be one, that endogenous inflammation, or it could be the drugs, what they have been put on, like the COCs or the GnRH antagonist or the agonist. All these things will suppress. So these are probably the reasons they give for increased incidence of this CVS and
in the continuum of care, what is emerging as a very strong monitoring is for cardiovascular disorders in women, because even in pregnancy, the hyperglycemia and the hypertensive disorders also progresses into the same. So there are many more women dying of that. So these also add to more number of reasons why we need to carefully look at them. And Tejavati is fully into this, issue of endometriosis. She says antioxidants are helpful. Relevance may be more compliant to the patient, and
even they are telling metformin can be used, aspirin can be used to revert the endomyometrial. That what is that? They say that exactly one terminology that revert that. Stiffness of the endomyometrial thing. Conversion to endometrium to that.
They will make it more comments. Looks like she doesn't want to have dinner so soon. She says if patient gets pregnant, stop the drug. And she also says no evidence so far regarding the effect of elagolix on the fetus. So, stop the drug and continue the pregnancy, or as you said, contraception, etc. So, Madhuri madam, again, is there any evidence of OHSS prevented due to elagolix or letrozole? If so, the dosage.
Yes.
No. Basically, it's cavagolin, that's what we use. Which is given for 8 to 10 days, which we start on the day of HCG trigger. And probably we should for freezol and not transfer in the same cycle and go for a frozen embryo transfer. And we have to monitor during this thing, but there's no role of using letrozole or antagonist in after oocyte retrieval for decreasing the incidence of OHSS. They also have some evidence in using calcium intravenously to decrease the incidence, but I have no experience with calcium. I do use gabagoline, and at times we do use starch. Initially, we used to use albumin, but today we no longer use albumin.
Okay, another 2 to 5 minutes, way too close, so really rapid fire, because I want to, respect and value the questions that so late in the evening some of our viewers have asked. Dr. Vijay Lakshmi Patnaik says, how long can you continue Visani, and elagolix causes severe sleep disturbances, hair loss, and vasomotor symptoms. So how to tackle that?
That is one problem. What my patients have been telling, hair loss is one thing with elagolix. So that is the reason sometimes if I go for a higher dose, maybe they are all bothered about the vasomotor changes. So my experience with elagolix is only of late. That is, I have not used beyond 1 year. But say Dynages, for even I have used for a period of more than 7 years. They are very comfortable. Some of the young girls, and especially these doctor girls, no doctors, they are very comfortable. They don't get the periods, they are happy. So unless till they get married. I have one more girl dentist. She says, I don't want to stop Dynages till I plan my pregnancy. So that is quite safe.
Okay. Then Jyotika Singh asks, kindly elaborate on dosage and duration of letroz in combination therapy for adenomas.
Yes, I give GnRH agonist or antagonist plus 2.5 milligram of letrozole for a period of for initially I give it for a period of 3 months, 12 weeks. So then assess the adenomyotic volume. Then after 3 months, there is a reduction, and there is thinning of the endomyometrial junction. That is one thing which I give importance. So when it is like that, I can stop and then plan for treatment. Otherwise, for some of my patients, I have used it for even for 5 to 6 months. Yeah. And Dr. Asha Rao and Dr. Kanti Pansal are also using the same protocol, and we do get good results.
Sure. So from the world of elagolix and relagolix, I want to go to Dr. Firoz's comment. Dr. Anu looks like Aishwarya Rai.
Hello, Dr. Firoza. Hello. We really miss you. Waiting for you to come to Ashray. And then you tell me in real sense, how do I look?
Firoz Azhar. He must be somebody different, but is truly appreciative of not only your talk, but also your looks. Sudeshna Naik, madam, how much Dynages dose and how much is the duration? Quickly, one last
duration is only 2 milligrams. The dosage is only 2 milligrams. It is never changed.
Duration you've already said.
Yeah.
Yeah. Sumit Verma, how long can we continue the patient on Dynages if she is already relieved by the drug? If she's relieved, then can you stop it?
She will get back the pain.
Okay. Yeah, Dr. Sheila Mane
At least minimum period of 2 years they need, because for the newer lesions to occur, it takes 2 years. So that is why they say post-operative suppressive therapy should be maintained for a period of not less than 2 years.
Yeah. So Dr. Sheila Mane says good talks by all, and I think she'll take Shobha Goody's comment and then institute through ICOG one strong teaching, intense deliberation on what people are doing in practice, what is the limitation, what are the challenges, what they really ought to do, because all these FAQs, I think we should put together and, try to concise it to make sense to a lot of others who have not attended this webinar. Dr. Varalakshmi says, these are last two questions. Post-surgery, ideally, what is the medication we should start and for how long?
So anything we can start. If the patient is not desirous of pregnancy, only we can put the patient on suppressive therapy. If she wants pregnancy, do not give any suppressant. Straight away start for fertility treatment. We can give any sort of progestin, Dynages or a medroxyprogesterone acetate. Right. And sometimes I find even Depo-Provera is very useful.
Sure.
It is low cost effective.
There are 3 comments by Dr. Lavanya Kiran. She says she also agrees with Madhuri Madam that quality of oocytes reduce in endometriosis. Yes. New combined medications reduces quite a lot of side effects as how it was just deliberated. Oral antagonists can also reduce the cost in cases of OHSs. Then finally, Tejavati is signing off saying thank you, very informative session on very complicated topic, very difficult to manage. And yeah, so I think, everybody has said, even again, one more, Ramya has asked about treatment of endometriosis in unmarried girls. If Ramya can quickly repeat that.
Yeah, I think Diniges will be the first line, or we can start even with oral contraceptive pills. But the thing is, we have to understand oral contraceptive pills will relieve only the pain, but not the underlying disease. But Diniges has got other, I think I have seen patients with ovarian endometrioma shrinking so beautifully when they are put on Diniges for a few months or quite few years. So I think first line will be Dinigest.
Excellent. See, we wanted to close at 10, but we are closing at 10:03. I think the speakers not only have done a brilliant job in their deliberation, but also really rapidly answered. I have not left out a single question from the audience. And thank you, audience, for really being alert, attentive, and finding value in this webinar called the Knowledge Cafe series, brought to you by artists and supported by Farmed. We truly appreciate that Farmed gives us a free hand in hosting as an academic partner, not insisting on what topic they would want to deliberate on behalf of the company. It's like really, in the true sense, an academic partner. So we really, really once again want to place on records their massive support in enrolling and engaging so many delegates, because each and every nook and corner of our country, they make it known that this webinar is happening, and there are exceeding expectations in each and every one of those. In fact, the Farmed representatives tell me that when they go with the next round of Knowledge Cafe, at every round, the doctors themselves ask, when is the next session going to be? And that is credit to all our very distinguished speakers here, with those like 53 questions answered so wonderfully and so rapidly. I really place my sincere thanks. But for the official thanks, somebody has been waiting very patiently, preparing his thank you note all evening. So I hand it over now to Dr. Divakar to place a formal vote of thanks. And as always, we thank Team Artists for the everlasting support, which makes us do much more than what we expected. Thank you, Divakar.
Thank you.
Thank you. It is an excellent session. I, on behalf of Hema Divakar, an artist, thank Dr. Anu Chawla, Director, London Fertility Clinic, for presenting on the use of AI in decision-making and diagnosis and management of endometriosis. Dr. T. Ramani Devi, Director, Ramakrishna Center, Trichy, for presenting a topic on why medical management is gaining preference in the management of endometriosis. And Dr. Madhuri Patil, infertility specialist, who spoke to us about endometriosis through the lens of fertility specialist in endometriosis. We thank all the delegates for joining in today's online webinar and making it a great success. I thank Dr. Pony Narayan, who did the MC work today, and I thank the Format Company for taking care of all the logistics related to this conducting this online webinar. Thank you all very much for the excellent speakers and excellent session. Thank you.
So until we meet you again very soon, 9th of June, we are having a session called PCOS Then, PMOS Now, by none other than Dr. Madhuri Patil, in conversation with Helena Teed, who have been leading this movement of the terminology change. So do join us on 9th of June. Again, it'll be at 3:30 p.m. and not at 8 p.m. to suit the timing of our international guests. Anu has been kind today, irrespective of whatever time in London she's joined us. So thank you once again, Anu, Madhuri, Dr. Ramani Devi, and all the team and the delegates. Namaste. Thank you.
Thank you.
Thank you. Good night.
Good night.
Thank you.